Hello and welcome to my Opthal teacher. My last lecture regarding diabetic retinopathy was on epidemiology, pathogenesis and signs of the disease. And this is the second lecture in the series and it's about the classification and stages of diabetic retinopathy. Why do we have to have a separate lecture is because the classification and the stages are numerous and they can be overwhelming for the beginners. So this series of lectures that I have uploaded about diabetic retinopathy, they provide a simplified understanding to the UGs and they can serve as a method of revision for the PG students. So they're going to benefit both. So let us begin with the classification. Now, the classification of the disease is based on the natural history of the disease itself. You see, the healthy retina with the intact basement membrane and the pericytes. And then as it begins, it starts with a non-proliferative type of diabetic retinopathy, where there is some basement membrane thickening, some tight junction failure, and microaneurysms are happening. After that, what happens is pericytes are lost and gradually there is new blood vessel formation. So proliferative DR sets in. Proliferative diabetic retinopathy sets in. So this is how the disease runs its course, right? So there are three classification systems. The first, the most widely adopted is the ETDRS classification, Early Treatment Diabetic Retinopathy Study. Please remember, I'm going to highlight all the landmark studies in green. Okay, I'm not going to have a separate class on the studies. It's enough to know the names, the full forms of these studies and the conclusion of these studies. So please note wherever I have highlighted the studies in green. So ETDRS classification was then modified and the modified Early-House classification is now widely used. An adaptation from the ETDRS and simplification of the ETDRS is the International Clinical Diabetic Retinopathy Severity Scale or ICDR classification, right? This is also followed by clinicians worldwide, right? And lastly, there is a clinical classification which I'll be explaining to you. So ETDRS classification, this is a must for the UG students as well as PG students. So this is a modified Early-House classification where the category of the disease is on the left side and its management on the right side. So talking about NPDR first, no diabetic retinopathy is is basically no finding in the fundus. So that is the first stage. Then comes mild NPDR or mild non-proliferative diabetic retinopathy. So any or all of microaneurysms, hemorrhages, hard exudates, cotton wool spots. All of these signs, the pathogenesis and the signs I've discussed in the previous lecture, so you can go back and revise. So any of these four findings up to the level of moderate NPDR, but no edema or significant venous bleeding. Okay. Now, I know it is a little bit complicated, this classification, but it is what it is, and it is still the most widely used. So you will have these four things, but you will not have venous bleeding or edema. That will constitute mild NPDR. And the management would be review. By review, I mean basically fundus examination every 6 to 12 months. Then comes moderate NPDR. Moderate NPDR consists of severe retinal hemorrhages. Now, what do you mean severe? Severe is when it is comparable to this particular standard ETDRS photograph. So what the ETDRS did was they gave standard fundoscopic pictures for you to compare with and grade the diabetic retinopathy accordingly. So severe retinal hemorrhages, if more than ETDRS standard photograph 2A, about 20 medium to large per quadrant in 1 to 3 quadrants or mild edema. What mild edema, moderate edema, severe edema is, you can refer to the ETDRS pictures anytime. Significant venous bleeding can be present in no more than one quadrant. Cotton wool spots commonly present. So what are the three things here? Severe retinal hemorrhages, significant venous bleeding, and cotton wool spots. Review in approximately 6 months, not longer than 6 months. That's what is moderate NPDR. Then comes severe NPDR. Now this is a constant, the 4-2-1 rule. This is a rule of thumb everybody should remember. So 4-2-1 rule consists of one or more of severe hemorrhages in all 4 quadrants, significant venous bleeding in 2 or more quadrants, and moderate in edema in 1 or more quadrants. So the hemorrhages have become severe and they are involving all the four quadrants, unlike moderate, in which it was less than four quadrants. Venous bleeding in two or more, here it was one, and IRMA in one or more. This is moderate. Here we had mild IRMA, right? So this is the 4-to-1 rule. The review is every 4 months, not longer than that. And very severe NPDR, if two or more of the above three criteria are seen, it becomes very severe NPDR, where the review should be 2 to 3 months. So this review, monthly, 4 monthly, 6 monthly, is only for NPDR. We are presuming that there is no macular edema here. If there is coexisting diabetic macular edema, then you have to review the patient monthly to 2 monthly, irrespective of the stage of diabetic retinopathy. As we will be discussing in subsequent slides, diabetic macular edema can be present in any particular stage of diabetic retinopathy, and then your management also changes. If there is no diabetic macular edema, and there is only NPDR, you simply review the patient accordingly. But if there is diabetic macular edema, this pattern changes. So NPDR, this was it. Now coming on to proliferative diabetic retinopathy. PDR or proliferative diabetic retinopathy requires management. So you see the word review has now changed to treatment, right? So mild to moderate PDR, new NVD, new vessels on the disc, or NVE, but insufficient to meet the high risk criteria. Treatment is advised. If not treated, at least review the patient in 2 months. This varies from clinician to clinician. If the PDR is not a high risk one and it is a low resource setting, maybe you can review the patient, but it has to be not more than 2 months. But ideally, PDR should be treated. High risk PDR, NVD greater than ETDRS standard photograph 10A, any NVD with vitreous hemorrhage, NVE greater than 12 disc area with vitreous hemorrhage. Treatment advised immediately, okay, for high risk PDR. So that's your ETDRS classification. So see for example, this is one of the ETDRS standard photograph. This one's 10A, okay. This defines the lower border of moderate NVD. NVD covering approximately 1/3 of this area of the disc, okay. This is the NVD over here, right. This is the NVD. This extent of NVD alone would constitute PDR with high risk characteristics. Why? Because the NVD is covering 1/3 or more of the disc area, right? So this becomes one of the criteria for high risk PDR. So you see what they did, grading diabetic retinopathy from stereoscopic color fundus photographs. So in this way, they have provided several photographs for us to compare with and classify the diabetic retinopathy accordingly. Coming on to a simpler classification, that is the ICDR classification. So here is the stages and here are the findings. No apparent DR, no abnormalities, same as ETDRS. Mild NPDR, only microaneurysms, okay, much simpler. Moderate NPDR, microaneurysms, but other signs also present, those 4 signs that I talked about, but less than severe NPDR, simple to remember. Severe NPDR, moderate NPDR with any of the following. So the 4-to-1 rule comes here, except that the 4 is modified. Intraretinal hemorrhages more than 20 in each quadrant, okay. Instead of intraretinal hemorrhages in 4 or more quadrants, it becomes intraretinal hemorrhages 20 in each quadrant. Definite 2 and 1 is the same, and no signs of PDR. PDR, severe NPDR plus 1 or more of the following, that is either neovascularization or vitreous or periretinal hemorrhage, okay. Either of these present classifies the disease as PDR, right? So this is comparatively simple to remember. And diabetic macular edema has also been classified by this international classification system. So no DME when no retinal thickening or hard exudate is present in the macula. Non-center involved DME. So see, diabetic macular edema includes not just hard exudates at the macula, but also retinal thickening, which is visible by a stereoscopic fundus photography, as we do with the 90D or the 78D lens on the slit lamp. So retinal thickening in the macula that does not involve the central subfield zone, that is 1 mm in diameter. This central subfield zone 1 mm in diameter, I'm going to explain to you when we talk about diabetic macular edema in the subsequent slides. So non-center involved when it does not involve the central 1 mm. and center involved when it involves the central 1 mm of the macula. Coming on to clinical classification. So ETDRS and ICDR, both either classification can be used, but remember ETDRS you cannot forget, you have to remember because it is a landmark trial. ICDR is a simpler classification, and clinical classification is for the sake of clinicians in their day-to-day practice. So you will call something as background diabetic retinopathy when you find only some microaneurysms, dot blot hemorrhages and exudates, and these are the earliest signs of diabetic retinopathy. So there is no comment on macular edema, there is no proliferative nothing. It is basically a sort of non-proliferative diabetic retinopathy, more or less. Okay. Diabetic maculopathy is when there is any retinopathy at the macula that includes edema, that is retinal thickening or hard exudates, or even ischemia of the macula, which can threaten vision. So this is the significance. Okay, all this classification are significance for carry significance for the clinicians. Then there is something known as pre-proliferative. Okay, so pre-proliferative is when the ischemic signs set in, that is cotton wool spots, venous changes, irma, and deeper retinal hemorrhages. This indicates progressive retinal ischemia with increased risk of progression of retinal neovascularization, or PDR. That is why it's called pre-proliferative. PDR, you know what PDR is, and PDR requires urgent intervention. Advanced diabetic eye disease is you can say it is the fallout of PDR, that is tractional retinal detachment, significant vitreous hemorrhage, and neovascular glaucoma. These are the three entities which compromise advanced diabetic eye disease, and it carries a poor visual prognosis. So just briefly going through each of these stages, this will just be a quick run through because you are already familiar with the signs. So mild NPDR is when there is only microaneurysms. You see this tiny red dot. So microaneurysms are classically smaller than 100 microns in size, and if bigger than 30 microns, they are clinically visible, else not. They are the earliest signs of DR. They appear as red tiny dots. And in order to differentiate them from dot hemorrhages, one clinical feature is that dot hemorrhages are usually larger than 125 microns, whereas these are limited up to 100 microns. The second way of differentiating is a fluorescein angiography, which helps to differentiate between non-thrombosed microaneurysm versus dot hemorrhage. Okay. Dot hemorrhage would be black, non-thrombosed microaneurysm would be hyperfluorescent or whitish. Microaneurysms can be solitary or clustered, and they remain stable, and they can even disappear once the sugar is controlled. So only microaneurysms here. Then coming on to moderate NPDR, more than aneurysms but less than severe NPDR. So this is something in between. So what will you find here? Dot blot hemorrhages, hard exudates, cotton wool spots, but no signs of severe diabetic retinopathy. So what do we mean by dot blot hemorrhages, hard exudates? See, you see these microaneurysms plus hemorrhages and hard exudates are present. Okay, there is no edema in this picture. There are no venous changes, just some tortuosity is there. Okay, and there is no neovascularization or anything to rule out PDR. Also, you have to know, very important, in what layers these various pathologies are present. So microaneurysms are commonly in the inner nuclear layer, dot blot in both outer plexiform and inner nuclear, flame shaped nerve fiber layer, hard exudates, outer plexiform, soft exudates, again nerve fiber layer. So you see most of the pathology is located here in the inner nuclear, outer plexiform, and the nerve fiber layers, because this is where the three capillary plexus, the superficial, intermediate, and deep capillary plexus is present. Okay, which constitutes the inner blood retinal barrier. We talked about inner blood retinal barrier in the previous lecture. Then comes severe NPDR, the 4-to-1 rule comes in. So 4 intraretinal hemorrhage and microaneurysms in 4 quadrants, venous bleeding in 2 quadrants or more, IRMA in 1 quadrant or more. So IRMA basically appears as very fine lines which run between an artery and a vein, and they are a sign of ischemia. Okay, so these are IRMA. Very fine, very difficult to appreciate, and very difficult to differentiate from neovascularization unless you do a fundus fluorescein angiography, which helps you know for sure. Then if you are following the ICDR classification, this particular criteria becomes 20 retinal hemorrhage in each of the 4 quadrants. Okay. So what is the clinical significance? There is a 15% annual chance of progression to high risk PDR, okay, when it comes to severe NPDR. So in this picture over here, you see there are hemorrhages in all the four quadrants. So that satisfies this particular criteria. Okay. Very severe NPDR, any two or more of the 4-2-1 rule. So intraretinal hemorrhages and microaneurysms in four quadrants. Venous bleeding in two quadrants, IRMA in one. So basically in this diagram, I've tried to show venous bleeding, which is present in three quadrants, may be present in the fourth quadrant also. So this satisfies the criteria for very severe NPDR. You see this sausage-like bleeding and thinning and thickening of the vein and segmentation. So that is the venous bleeding or the venous changes present in three quadrants of the retina, which satisfies this criteria of very severe NPDR. So that was 15%. This one's 48% annual chance of progression to high risk PDR. Next, coming to diabetic macular edema. What is it? It is defined as retinal thickening caused by accumulation of intraretinal fluid, primarily in the inner and outer plexiform layers. The word intraretinal is important because there are conditions with some other underlying pathologies which cause subretinal fluid accumulation. Okay, so you have to know that the fluid here is intraretinal. Hyperpermeability of the retinal vasculature and can be present with any level of diabetic retinopathy. So even a mild NPDR can be associated with some amount of diabetic macular edema, albeit mild or moderate variety. The risk factors for diabetic macular edema to occur are long duration of diabetes, poor glycemic control, coexisting nephropathy, hypertension, dyslipidemia, pregnancy, and post-intraocular surgery. Diabetic macular edema is known to worsen after cataract surgery. Symptoms. Now, anything that involves the macula is going to affect vision, right? So there will be blurry vision. There is metamorphopsia, as you can see here, straight lines becoming wavy. Micropsia or smaller than normal appearance, difficulty in reading, and rarely altered color perception. The patient may even be asymptomatic. So you should know how important it is to screen the diabetic patients. Just a diagrammatic representation of the pathology happening. So it can be either a microaneurysm which lacks pericytes, or it can be a damaged capillary from the reactive oxygen species and all those mechanisms that we discussed. So damage to the blood vessel, leaking out of fluid and lipids, causing thickening of the retina and presence of hard exudates. This is what you see in the underlying picture. This picture is known as an optical coherence tomography. I'm going to talk about imaging in diabetic retinopathy in my next lecture. So optical coherence tomography, or OCT, is basically a non-invasive technique of seeing the retina at a microscope, a cross section of the retina at the microscopic level. Okay, so you can easily make out the layers over here and where the fluid is present. So you see these dark pockets. These dark pockets are fluid pockets, and what you see here is a cystoid macular edema. These hyper reflective or white things are the hard exudates. Okay, we will be talking about both optical coherence tomography and fluorescein angiography in details in the subsequent lectures. Classification of diabetic macular edema follows these four systems. So there is ETDRS, International Classification, FFA, and OCT. So diabetic macular edema, it is important to read this topic separately because it is a complication that is assessed separately from the stages of retinopathy, as it can be found in eyes at any level of DR severity, and it can run an independent course. It is the most common cause of visual impairment in patients with diabetic retinopathy. So ETDRS, the study classifies macular edema as clinically significant macular edema. Okay, so there are three criteria. Now, again, examiners can ask you the definition of this clinically significant macular edema, this particular classification, because it has been given by the ETDRS, which is a very, very favorite study. So CSME can be any of these 3 points, right? So retinal thickening at or within 500 microns from the center of the macula, as in this picture. The red part is the retinal thickening, and this is the center of the macula, 500 microns. Okay, so this is the first criteria. Then hard exudates at or within 500 microns from the center of the macula if accompanied by thickening of the adjacent retina. So both thickening, if hard exudates are present, they must be associated with retinal thickening also, and they should fall within the central 500 microns. So you see there is hard exudates and retinal thickening. And the third criteria, a zone of retinal thickening, which is one disc area or larger in size. You see this is larger than the disc area, right? Any part of which falls within this circle, that is one disc diameter or less from the center of the macula. So you have to memorize this. If you cannot understand, you have to memorize anyway. That's ETDRS classification, retinal thickening plus hard exudates, and retinal thickening. So basically you have to consider both the things. Again, this is the first one, retinal thickening. Here, the gray part, retinal thickening, and this is the central 500 microns of the macula. So this is falling in that circle. Again, retinal thickening plus these yellow dots showing hard exudates falling within 500 microns. And the last one, retinal thickening greater than one disc diameter in size, falling within one disc diameter of the center of the macula. So that's the three criteria. All these three pictures satisfy the criteria for clinically significant macular edema. Then comes the ICDR classification. ICDR classifies macular edema as non-center involved and center involved, and it uses 1 millimeter diameter, the central 1 mm zone rather than the central 500 micron zone. Just double, just to remember. So no DME is no retinal thickening or hard exudates. Non-center involved when the thickening is present, but it does not involve the central subfield zone that is 1 mm in diameter. I'm going to explain this central subfield zone, what this means in the subsequent slides. So this is the central subfield zone of 1 mm diameter. Okay, it is basically nothing but a circle of 1 mm diameter centered on the center of the macula. So this, as you can see, is 1 mm diameter, and this is 1.5 mm diameter or one disc diameter. So whenever we are measuring things in the retina, we can compare it with the size of the disc. That is why often you can see lesions being described as certain disc diameters in size, because one disc diameter is measurable and it is equal to 1.5 mm. So this is non-center involved DME because the exudates are falling outside this 1 mm circle. Non-center involved. Center involved DME, the exudates are falling within the circle. So this is another classification, right? So this is what you mean by the central subfield 1 mm. This little tiny circle over here, you see, this corresponds to the central subfield zone of the macula. That is the central 1 mm of the macula. So in this case, the thickening as denoted by red, like red is the thickest, followed by yellow, followed by green, which is normal retina. So this is not really falling in the central subfield zone, whereas in this picture, that retinal thickening is within the central subfield zone. So that's the difference. Then the third is the FFA classification. So FFA classification, based on the appearance, the leakage of the fluorescein dye that is injected into the body from the retinal vessels, we classify. That is what is FFA is about, or fundus fluorescein angiography. It is just like angiography, the angiography, the cardiac angiography that we know. It is the same, but visualization of the retinal vasculature. So a vein, in the antecubital vein of the arm, the fluorescein dye is injected, and then these fundus pictures are taken with the help of a special camera. Right? These pictures. These are the FFA pictures. This is a normal fundus, color fundus picture. And this is an FFA picture. There is a special camera for this. So these pictures basically detect the fluorescein dye and its presence in excess or its absence as light and dark areas. So wherever there is more of a dye, there will be these hyperfluorescent or white areas, and wherever there is ischemia, the dye will not reach those areas and those areas will appear dark. Just know this much. So it can be focal versus diffused. Now, focal macular edema, you see this circular pattern of hard exudates here. This is the macula, right? Right. I mean the center of the macula, and this is the hard exudates over here, right? So this is known as circinate retinopathy, just a term given to a circular arrangement of hard exudates in the macula. It can be complete ring or incomplete ring. So when you do an FFA of this particular person, this is what it looks like. You do not see the hard exudates. These whitish thing that you are seeing is basically the leakage. Okay, the hard exudates have obviously come from leaking vessels, right? So this is a area of leakage. You can pinpoint. So that this is a well-defined area of you can actually localize that, okay, the leakage is happening from here. So this is focal type of diabetic macular edema, and this is amenable to treatment, a localized laser treatment which can seal off the leaky vessels. Then we have diffuse macular edema, in which you cannot really make out the retinal thickening, okay, like in this picture. And when you do an FFA, you can see some leakage, but then the leakage is going to increase in with time, and it's going to increase in area. Right, this is just one picture. You will find that this leakage is going to spread, it's going to be diffuse. You cannot really make out the limits of it. So this is diffuse macular edema. This is the FFA classification of macular edema. Again, it can be ischemic versus non-ischemic. Ischemic is when it looks dark like this. I'm going to show you in the next slide. So you see, this is basically an ischemic sort of macular edema. Now, as you can see in this picture, there are just hemorrhages and some soft exudates and some hard exudates, right? That's all you can see. You cannot make out, in fact, there are no hard exudates. You can just make out some hemorrhages, some vascular changes, maybe dot and blot hemorrhages, flame-shaped hemorrhages, and cotton wool spots. You cannot appreciate retinal thickening. You cannot see any hard exudates over here. But what when you do an FFA, you see, look at this area, this dark area, right? And these dark patches over here, these are ischemic areas, the darker ones. Areas where the fluorescein reaches must appear white, like these areas. Surrounding areas appear whitish, but then compare them to these areas, dark. Again, this area is dark. This area is dark. This is suggestive of ischemia. So this is a case of ischemic diabetic maculopathy, right? And this is known, this dark thing, the technical term for it is hypofluorescence. So non-ischemic, again, non-ischemic is basically when you can actually appreciate the retinal thickening or the hard exudates, and non-ischemic can be focal or diffuse, as we saw. So this one's well circumscribed. This is diffuse retinal thickening. And you can see a focal hyperfluorescence in case of focal and diffuse hyperfluorescence in case of diffuse. Simple. Ischemic, it's variable, the clinical picture. There may be just hemorrhages. It may even look normal, but then when you do an FFA, you will see capillary non-perfusion areas or ischemic areas or dark areas in the fundus fluorescein angiography, not just at the fovea, but also surrounding it. Now coming on to PDR. PDR stands for proliferative diabetic retinopathy. So there, you see how the stages have progressed from no diabetic retinopathy to non-proliferative, mild, moderate, severe, very severe to proliferative diabetic retinopathy. There are just two criteria, one or both of neovascularization or vitreous / preretinal hemorrhage. Now, neovascularization can be on the disc, it can be elsewhere in the retina, it can be on the iris also. What do these new vessels do? They bleed. So this is the hemorrhage, right? The importance of this classification is that 50% of patients with severe NPDR progress to PDR within 1 year. I mentioned this figure when I talked about severe NPDR also. So the hallmark of PDR is neovascularization. So NVD, this is the definition of NVD, neovascularization on or within 1 disc diameter of the optic nerve head or the optic disc, right? NVD, NVE, neovascularization away in the retina, away from 1 disc diameter from the disc, and NVI is new vessels on the iris. Okay, so these new vessels, they are fragile. They do not have the tight junctions that are present in the normal blood retinal barrier, as a result of which they are leaky. Moreover, these new vessels tend to cause inflammation and fibrosis, and they tend to grow into the vitreous. They do not grow on the surface of the retina flat. They tend to grow into the vitreous, and that is what differentiates them from IRMA. Non-perfusion of at least more than 1/4 of the retina would cause development of PDR. So for proliferative changes to develop, at least 1/4 of the retina should be compromised. Retinal hypoxia clinically manifested by capillary closure and capillary dropout areas, both of which appear as dark areas on FFA. The characteristics of NVE, I already told you, they lack tight junctions, so they leak fluorescein. They also leak other things like fluid, blood. They are fragile and they bleed and cause vitreous or retinal hemorrhage, and they can be associated with fibrosis and membrane formation, which ultimately leads to tractional retinal detachment. High risk PDR. Now, another study, diabetic retinopathy study, it classified PDR into two types, non-high risk and high risk. So high risk PDR can be any one of these points. Any NVD, neovascularization at disc plus vitreous hemorrhage, or any NVD more than 1/4 disc diameter plus minus vitreous or preretinal hemorrhage, any NVE more than half disc diameter plus vitreous or preretinal hemorrhage. Please try to memorize this as it is. Okay. So what do you see in this picture? You see these fragile vessels, these frond-like vessels. When you see them with the help of an ophthalmoscopy, you will find a three-dimensional thing that they appear to be growing into the vitreous. All right. So this is your NVD, and this one's NVE, right? So I hope that has clarified the definition of NVD and NVE. Now, what is the high risk here? There is the high risk of severe vision loss. And what is severe vision loss? Snellen's visual acuity less than 5/200. All of these definitions, this definition of severe visual acuity, this risk, and these things have been given by the DRS study. So another landmark study, these are the conclusions of the study, and you have to remember this, especially for PG students. So by severe vision loss, we mean 5/200. Why this particular benchmark is chosen? Because at this level, visually guided ambulation becomes problematic. That is, the patient cannot even move around on his or her own. Again, a picture of new vessels on the disc, and these vessels have bled and caused a preretinal hemorrhage, which you can see as having a boat shape. Then new vessels on the disc and fibrous proliferation. This fibrous proliferation tends to grow into the retina, into the vitreous, and it tends to pull the retina, causing tractional retinal detachments. So the fallout of PDR is advanced diabetic eye disease, where there will be persistent vitreous hemorrhage. Persistent means more than 3 months. Tractional retinal detachment, as in this one, and neovascular glaucoma. Here you see these new vessels on the iris. So this is rubeosis iridis, and the same new vessels were present at the angle also. I could not show you a gonioscopic view. So there is NVI, there is NVA, as a result of which the IOP is increased to 60 mmHg, and this is known as neovascular glaucoma. So thank you for listening, and I'll be talking about imaging in diabetic retinopathy and starting the management in the subsequent lecture.